أرحب بجميع الأخوان والأخوات في هذه المحاضرة لشهر مارس. In this grand round, we will be addressing the bone pathologies related to certain gynecological problem of the young. And that is related to hypoestrogenism of the young. The two main diseases that we encounter relevant to this topic is premature ovarian insufficiency and functional hypothalamic amenorrhea. We will have a review of translational literature, and we'll have some case discussions, and we will not be having any polls because that's only been run in our streamlined webinars, monthly webinars. In terms of pathogenesis in females when they have low estrogen at any age, there will be a drop in the osteoprotegerone, increase in the rank ligand availability, and increase in the inflammatory cytokines, in particular IL-6, 1, and 7. And this has been corroborated in many papers. And the rank ligand osteoprotegerone pathway is infamous for its impact on the bone. The rank ligand, as we all know from previous lectures, that is produced by the osteoblasts, and it acts on the stimulating the precursor osteoclasts to mature and start bone resorption. Now the OPG, what it does is simply antagonize that effect. It's an antidote for rank ligand, and it's simply its decoy receptor. The OPG is reduced substantially when you have when the estrogen level drops down, and it's the same result you will get if you give the patient glucocorticoids. The OPG is a glycoprotein secreted from the blast cell, both the osteo and the fibroblast, and as mentioned, it's a decoy receptor of the rank ligand, and therefore it's an anti-resorptive cytokine. And it also promotes the differentiation of osteoblasts as a local effect, besides antagonizing the rank ligand. Outside the bones, the OPG actually has attracted a lot of interest amongst the scientists to investigate its role in the vasculature, and there is now they are now validating the levels as an indicative marker of atherosclerosis, just like the high sensitivity CRP. ولكن هذا يعني موضوع بالحقيقة اتضح ب يعني جوانب متعددة. It seems to be that the levels of OPG in normal physiological status, it protects the vasculature from calcification. Now, there is an associated relationship between raised OPG and high cholesterol hypertension and even Charcot disease, and any inflammatory condition that could affect the vessels locally. However, its main job is a protective mechanism, and this protective mechanism can increase into maladaptive levels. Like many other mechanisms, start to protecting the vasculature in certain ways, and then become counterproductive or counterintuitive. So يصبح لها دور عكسي من ترتفع لفترة لمستويات عالية ولفترة طويلة. هذا المقصود بها. Now back to the areas of interest, that is the estrogen receptors in the bones. Now there are different isotypes of estrogen receptors, alpha in the trabecular bones and beta in the cortical bones, and the alpha receptors has a much higher affinity for estrogen than the beta receptors, and therefore قد يكون هذا هو السبب why in low estrogen female tend to lose more trabecular bones than cortical bones. So hypoestrogenism is a state of high bone turnover with a predominantly trabecular bone loss. It's a state of accelerated vascular atherosclerosis, and that's been well established in many, albeit animal data. ولكن هذا الموضوع particularly of interest in the two topics that I'm going to present today. The reason is known now that estrogen, through its myriad effect and multi-target effects, it promotes cell action and replication, proliferation. It ensure availability of other hormones through its impact on sex hormone binding globulin. And it does modulate catecholamines and regulate favorably intracellular calcium. But however, one of the principal pathomechanism is induced nitric oxide secretion. This is a study that is done on females known to have menopausal females known to have ischemic heart disease, and it showed that by giving sublingual estradiol, that the time to develop ST depression on the treadmill on the stress test has prolonged by at least 1 hour, well, by an average of 1 hour. This is here another study that at which they infused the estrogen IV for both men, female and males with known ischemic heart disease, and they measured the coronary blood flow, and it seems to that has a positive impact on significantly increasing the blood flow in females by about 20 folds in comparison to men. The reason being that you see this impact on blood flow in females only because the females obviously have about 10 times more estrogen receptors, or the levels of the premenopausal level of estrogen is 10 times that of men. Besides the availability of the abundance of availability of estrogen receptors. The famous elite study, and they studied the carotid intimal media thickness, and what they see here in the premenopausal, in the early menopausal groups, if they treated with if you were treated with placebo and the red dotted lines, or with estradiol, you can tell that the estradiol treated group at an early menopause has a much thinner intima in comparison to those on placebo. Now, this difference seems to be lost in if you were to provide estrogen in the later menopausal group. And the cutoff here between early menopause and late menopause group was 6 years. So we're back to the timing hypothesis again. This is the WHI, the infamous WHI study that showed that in terms of endpoints, the coronary heart disease, stroke, total mortality, etc. In the two interventional group, either estrogen alone or estrogen combined with MPA, there were no difference in the endpoints, and they all crossed the unity line, how except one group. And that is the group of patients who started the treatment 20 years after menopause, after their last menstrual period. So it's they were a very old population, and there seems to be there's increase in the in particular of coronary heart disease in the combination group. Even the estrogen alone by itself did not cause this problem. So we think it's actually the progesterone has caused this problem, not the estrogen. With a hazard ratio of about 28% increase, and in absolute terms 17 per 10,000 person years. And as we know that the stroke result of this study was inconsistent, and a summary of this, one of the conclusions of this study was that a combination therapy can have detrimental effect in older menopausal females' coronaries to some extent, and we think it's actually the progesterone has caused that because it down-regulates the estrogen nuclear receptor. Now, back to the point of familial or functional, hypothalamic amenorrhea, which is defined by suppression of the HPO axis for no anatomical pathology, and that will drive either irregular or absent. I mean, it doesn't have to be, بمعنى أنه it does not have to be amenorrhea. Hypo or oligmenorrhea can be included in this diagnosis. This is the reason why it happens, and this is the GnRH. That's what gets affected by its connection, strong connection with the candy neuron receptor in the median eminence here. And you can tell there's a lot of receptors in the medial eminence. In particular, of interest is the leptin receptors and the insulin resistance receptors, and POMS and CARTS and GABA, and of course the MPY. So, you know, there's a lot of factors that could switch off the candy neurons, I should say, actually, it affects the stimulation of the candy neuron in such a way that it actually switch off the GnRH stimulation. هذا موضوع, and each one of these receptors and its impact on this pathway has been studied separately and has no role in today's discussion. We divide functional hypothalamic amenorrhea into either that of the athletes and the non-athletes, and they both have different mechanisms or etiologies. Again, the principles of diagnosis of this condition is there's no structural pathology, amenorrhea for a good 3 months, or oligmenorrhea, or periods that's prolonged beyond 45 days. So females who have regular periods but they just delayed, they will fall into this condition, which is reversible and has a strong genetic predilection. Historically, the triads of this condition is amenorrhea with low bone and disordered eating has been recently titled as relative energy deficiency in sports, or REDS, because men can get the same problem, hypothalamic or functional hypothalamic hypogonadism. Now, in this paper, it looked at the percentage of patients who develop this condition, or percentage of athletic females who develop this condition. And it seems to be primarily on the weight-bearing sports. And you can see here in the ballet dancers, percentage about 79% will have some irregularities in their period. وهذا اللي يحصل حقيقة بالأثليتس يعني they start having irregular periods on and off. So it doesn't happen overnight, and it doesn't have to be a cutoff. So if you have a female who have a strenuous physical job, and you know, and she start telling you that I started notice that my period has become irregular, you know that she's heading towards FHA. Again, in marathon runners, however, in cyclic, those who cycles or swim, that's not non-weight bearing sports, the percentage of the chances for them to develop this condition is a lot less, 12% or thereabout, in this paper at least. This is another study that showed they looked into athletic and female athletes, those who cycles, they're still having their regular cycles, and those who are amenorrheic, and they compared them to the control, who were sedentary, non-athlete with regular periods. And you can tell, they looked at the LH secretion, and you can tell that the LH in the cyclic females are more frequent, has presented more frequent pulses. The cyclic athletes has less frequent but higher amplitude LH, and of course the amenorrheic athletes has scarcity of LH pulses. And the difference between these two groups, the athlete groups with periods and those without, is that the first group were provided with enough calorie diet, and therefore in the sport world, these athletes, both men and women, حقيقة, they have a sport dietitian to ensure they having enough calories to meet their strenuous exercise program. And in this papers and others has showed that low calorie intake will reduce the LH pulse frequency, amplitude by about 50%, and I think this is a striking fact, and this applies for both men and women. Now moving on to leptin hormone and adipocytokine correlates strongly with the body fat mass, and we started to know, I showed you, as shown in the candy neuron slide, that it has an important role in affecting the GnRH, and the at which low level of leptin that could develop with energy deprivation, it actually signals that there is an energy deficiency. This is the philosophy how this hormone acts. When this hormone drops down, the candy neurons start signaling to the GnRH that we're actually facing a low energy status, and therefore we need to spare this energy to more vital organs. The reproductive system requires a lot of energy. This is a couple of papers I pulled out for you, and cases were examined when they leptin deficient here, and due to low energy, and you could see that the leptin level in the dots, in this case dotted line here, and the LH in the black line in this case was actually flat, and the other case study was showing very infrequent pulses. Once you inject them with leptin levels and the leptin level goes up, the LH starts pulsing in both two patients. Another study here that showed once you inject them with the leptin subcutaneously, of course, the follicle size will increase, the ovarian volume will start to go up. The follicles, number of dominant follicles will increase, and the uterine endothelium, it's all indicative. Uterine endothelium also obviously will become thicker, all indicative of higher estrogen environment availability. In these two papers, I hope you, in the first paper, they looked at the leptin levels and how it drops down بمجرد انه you cut down on the calories. In these two groups, they were of similar BMI, so it was adjusted against BMI. They only reduced the calorie intake, and the group that has the calorie restrictions, that's the black dots, has immediately shown a drop in their leptin levels. Another paper here looked at again, through three groups of patients: amenorrheic athletes, athletes who are still uh, cycling, and of course the non-athlete cycling females. And you could see that the LH levels actually follows the leptin levels. Low leptin, low LH pulses and frequency and amplitude. As the leptin level start to go up, and this through injection of subcutaneous leptin, behind the paper. Once you inject the leptin and the leptin subcutaneously, and serum levels start to go up here, and in the athletes start to having their periods again, and same applies for the leptin levels. Now, they did not inject ghrelin, but they noticed as you inject leptin, the ghrelin levels start to drop down. This is another paper addressed the growth hormone pattern and level in the non-cyclic athletes, and what seems to be happening here, that the growth hormone total daily secretion is increased, but that's primarily driven سبب انه overnight growth hormone pulses and frequency increases, not during the day. So there is a pattern here, and that's another paper addressing the same problem in the hypothalamic or hypothalamic amenorrhea, or in the amenorrheic group. The overnight growth hormone from midnight till 8 a.m. frequencies increases significantly. So that's another hormone findings we get in functional hypothalamic amenorrhea. And in relation to cortisol level and insulin resistance, as we all know that the insulin resistance drops down substantially once you cut down the calories, irrespective of the body mass index. And in this study, they adjusted the insulin level and the insulin and the cortisol level against the IGF-1 binding protein, and they noticed that the open circles are the controls, and the black dots are the active arm, and how the levels increased during in the non-cycles, in the normal cycles, females in the white or empty circles are lower than the hypothalamic females in the black circles, both the insulin and to some degree the cortisol levels. There is an overlap, as mentioned in previous lectures, ما بين ال reproductive metabolic syndrome اللي سابقا المفروض نسميه PCOS سابقا and the FHA. So almost half of the RMS patient, they have some degree of FHA. بعبارة إنه تعالج ال PCOS, the patient loses weight and they still having irregular period beyond that. So how do we differentiate in terms of biochemistry? We know in RMS the LH tend to be high, with the exception of the morbidly obese. The FHA is the other way around. Sex hormone binding globulin will be low due to insulin resistance in RMS and high in FHA. The androgen can, usually but not always, and the follicle distribution on ultrasound, PCOM, and the LH to FSH ratio tend to be much higher in the RMS, and no more than twice, well, actually 1.5. The ratio they used in the papers was, and anyone with LH FSH ratio more than 1.5 were excluded in these in the FHA paper studies. So they could be slight elevation in the LH, but not as much. No more as twice as the FSH in the hypothalamic group. And finally, we have well, not finally, another important group of patients that falls into the FHA is the anorexia nervosa. Now, the vast majority of these patients will have either amenorrhea or oligomenorrhea. These patients tend to have a low bone density scan. That has been studied over and over again. It's in this particular cohort of patients مو بس عندهم الاستروجين قليل وإنما they will have high cortisol, low thyroid hormone, low IGF-1. Now, a more common problem in my view is the stress-related FHA, which is not dietary induced and it's not related to sport or rigorous sport, and that's the stress relationship. So severe depression or anxiety, it has to be severe, either acute or chronic. And in this paper, they actually found that more than 90% of the patients actually have normal BMI. Some of them were even overweight, but they still develop FHA. The mechanism, it goes like this. During severe stress leads to reduction in the FSH pattern depicted here by the blue line in this Victorian paradigm of gonadal hormones. So in the late follicular phase in particular, the FSH will not go up as it should be, and usually it starts to go up here, the estrogen follows, and you will have the LH in the pink line here following all that to induce ovulation. Now in severe stress, the FSH in blue is actually suppressed. The estrogen will not go up, therefore the estrogen will not level will not increase, and subsequently you will not get the LH excursion. Now, if in this study in this paper, actually they gave IV 100 microgram of CRH, and that was enough to drop the LH by about 50%, both in the follicular phase and the mid-luteal phase. It just shows you the impact of CRH on the gonadotrophs. This is another elegant paper in '89, and what we're looking at here is the cortisol, FSH, LH levels once you start infusing CRH in the white circles. And the black circle represent control being infused with normal saline. And what happens, of course, when you infuse CRH, as you would expect, the FSH start dropping down, the LH follows, and the cortisol level goes up. Now, in the second phase of this study, what they did is they continue infusing CRH, but they infused naloxone at this juncture here. من يعطونا naloxone, what they notice is actually the FSH start to go up, the LH start to go up, and the cortisol level plateaued and eventually dropped down. بعبارة أخرى, إنه it seems to be that the opioids released during CRH infusion are responsible for the CRH-induced decrease in the gonadotrophin. إنه CRH inhibit the GnRH through opioid release. So CRH stimulate opioid secretion, will opioid suppress the gonadotrophs. This paper was that theory, which was done in humans, is actually driven by rodent and non-laboratory, non-clinical models in adrenalectomized rodents. And what they noticed that once they take the adrenal out and they infuse with CRH, ومع ذلك the ovarian volume still drops down, and therefore we think that the mental stress inhibits ovulation through inducing endorphin secretion, which in turn will inhibit the GnRH. The impact of physiological hyperprolactinemia is very minuscule, minimum, and modest, and doesn't have much impact on the GnRH in these circumstances. So this diagram is just show you the how this pathway works. You get stress, stimulate CRH. This will stimulate endorphins, and therefore blocking the GnRH secretion. So if I were to reclassify FHA, I would say the first and most common group of FHA are the psychological stress related to severe either acute or chronic depression and anxiety. Nutritional is known to cause the same problem, but you have a prolonged restrictive nutrition and calories to get that. And of course the REDS group. And in summary, there's a myriad of hormone changes in this condition. Low leptin stands out, I guess, in this group, and amongst, of course, eventually ending up with low estrogen status. And please don't forget, there is a strong association between this case and or this condition and RMS. Half of RMS, almost half of them, will have hypothalamic, functional hypothalamic amenorrhea or oligmenorrhea. Even though you treat the RMS, the patient will still tell you that, you know, I've still got my periods irregular. So that's in a nutshell. Now, how do we clinically evaluate these conditions? In terms of history taking, I tend to ask the patient about their diet, if there's any new onset or worsening of their depression status, exercise, if they do exercise, and the weight history, how much weight you've lost or you gained. لأن نعرف احنا بالRMS you have weight gain that trigger the RMS. In functional hypothalamic amenorrhea, you have a weight loss usually trigger the condition. So completely opposite direction. So what sort of weight changes you had in the lead to the amenorrhea؟ ايش قد عندك صار تغيير بالوزن الى ان صار بدأت البريود؟ فيقول لك خلال السنة الماضية زاد عندي وزني بحوالي 15% او ما اعرف الى اخره. Do they have unusual headache? So we can start thinking of pituitary, polyuria, polydipsia. And I tend, as an endocrinologist, to ask for polyuria, polydipsia for every single person who walked through my room, regardless, because that's how we start picking up on pituitary hypothalamic pathologies. On examination, of course, we look at the BMI, Lanuga here, pituitary examination in terms of reflexes and visual field. Investigation-wise, I tend to do bone mineral density at baseline. The intention is not to treat with bisphosphonate مثل ما راح أذكر ببقية السلايدات, but at least you will have a baseline study. Now, ultrasound only required if the female had primary amenorrhea or seeking fertility, or she had another gynecological problem, endometriosis or whatever happened to be. So we don't do pelvic ultrasound routinely just because the female is having a regular period. The same thing applies for pituitary MRI. We do not require it routinely unless the patient reports unusual headache, polyuria, polydipsia, for example, or you have visual field restriction on your examination. We are bound to check the beta HCG. You don't want to miss out on pregnancy. ومثل ما قلنا لحضراتكم ال LH عادة يكون less than 1.5 higher than the FSH. You are bound, of course, you're going to check the thyroid, the prolactin. I'm not sure if يعني ممكن check baseline cortisol, particularly if there is a clinical indication of Cushing's. And the androgen profile, including the estrogen, and you could consider this is actually I do it very often, the progesterone challenge test. لأنه هذا حقيقة يقول لك إنه there is an estrogen based environment or not. It tells you, are you dealing with RMS or are you dealing with FHA? This is one of the principal distinguish test. So if you give her progesterone for 10, 12 days and you wait for a withdrawal bleed, if it happened, this is more likely to be RMS. If it didn't, then this is central condition. لأنه ما عندهم enough estrogen. How do we manage? Of course, in terms of bone health, vitamin D and calcium and nutrition. Just make sure they put on a couple of kilograms. And of course, psychological assessment, cognitive behavior. And the whole idea, the essence is to restore energy balance. And as mentioned, it's not uncommon to remain amenorrheic for after weight correction, and this will underscore the importance of psychological factors. لأنه يعني it does not exclude the diagnosis just because they did not resume حتى بالfunctional hypothalamic amenorrhea. It doesn't include the diagnosis someone who doesn't have RMS or just a pure FHA or a mere FHA. You correct the weight and they're still amenorrheic because they have an underlying psychological problem. So I think the picture اللي دا أحاول أرسمها إنه periods irregularities can start earlier on once the female develop stress levels start to go up or physical levels start to go up or the weight start to drop down, and they don't develop overnight. They gradually become irregular and then they stop, and they don't resume cycles regularly immediately. Again, because there's a lot of factors intertwined with each other, psychological, على dietary إلى آخره. Now I'll start with this case. I'll start the other half of the presentation with this of POI with this case vignette of 21-year-old lady whom I saw with secondary amenorrhea, 12 months secondary amenorrhea. She had amenarche at the age of 16, and she always had infrequent periods. She denies any hot flushes, and she had a normal BMI of 22, reasonably breast development and pubic hair growth. FSH is strikingly elevated with a low concomitant estradiol and normal gender karyotype, as we all should do, and antibody for celiac thyroid adrenals were negative, and pelvic normal ultrasound and normal prolactin and thyroid hormone. DEXA scan, I've arranged for her to have a bone density scan that showed the Z score on the low side of minus 1.9 at the lumbar spine. Pardon me. And the question is, shall we give her contraceptive pills or estradiol levels with cyclical progesterone or bisphosphonate even, or just we get shuttled or sheltered with adequate calcium D and bit of exercise. And I'll take you through the literature the next few slides to show you which of these are the best option in these circumstances. This case takes us to the topic of the second topic of tonight, that's premature ovarian insufficiency. It encompasses oligmenorrhea, amenorrhea, polymenorrhea, or metrorrhagia. The gynecological presentation, it varies a lot. You can easily miss out on the diagnosis. Amenorrhea need to be for at least 5 months, and FSH has been somewhat universally suggested to be more than 25, so 3 times upper normal. Now, again, I have to underscore the fact that it can present as polymenorrhea or metrorrhagia. 1% of females under the age of 40, so 1 out of 100 will could have POI, and 5% under the age of 45. Now, between the age of 40 and 45, we label that as premature menopause, but under the age of 40, it's a POI, and it's just I think it's a continuum, and these cutoffs need to be readdressed in the future. I think POI need to be considered as below the age of 45. Generally speaking, the vast majority or the majority of these cases are iatrogenic. Some of them, well, a lot of these cases are iatrogenic, and some of them can be idiopathic, and the other ones will autoimmune. So the least thing you would find is the antibody positive against the ovaries. Iatrogenic, by that I mean those who undergoes oophorectomy. So bone mineral density has been extensively studied in this group, and you can tell in POI against the that paper control against the ANES group historical control. It just shows you that in any domain you look at it, they score lower bone density: femoral, total, hip, lumbar spine, you name it. They're all lower than the control. The risk factors for significant deterioration in bone mineral density is if they already had a baseline of low BMI, if there is a delay in the diagnosis for more than 1 year, or if the age of POI onset was below 20 years. يعني إذا female صار عندها POI at the age of 38, she's not at risk of if she were to have it at the age of 18. And that's a common sense. And these are I pulled up here a list of conditions, congenital syndromic condition that can be associated with POI. In particular, I'll draw your attention to CAH17 hydroxylase type of deficiency. And these conditions supposed to be diagnosed in childhood by the pediatric endocrinologist. And the infamous Fragile X, but it's usually associated with cognitive impairment. Now I'll move on to this paper which shows two or three groups of patients. The healthy control, the other two groups with the white and black circles represent the POI groups. Y circle treated with estrogen and progesterone and placebo, and the other one is treated with estrogen, progesterone, and testosterone. And what it shows that the healthy group has a lower BMI, and the POI group, once you give them estrogen, they tend to have a higher BMI long term at the femoral neck. This was studied, and the femoral neck in particular, which is not a trabecular bone, by the way. It's a mixed bone with a predominantly cortical component. It's a proof of concept study, and essentially what it shows that the testosterone group, or third arm, did not have much bone density difference than the other group, which was treated without testosterone. And it just shows you that the impact on the bone mineral density is driven primarily by the estrogen supplements. So estrogen therapy in both POI and FHA. Estrogen therapy here, I'm referring to whom do you give estrogen in the functional hypothalamic amenorrhea and POI, and what sort of estrogen you give. This is a systematic review in looked into 9 studies for both athletes and non-athletes FHA, and the use of oral menopausal hormone therapy, or if you like replacement hormone therapy, or OCP in FHA, and there was no significant in BMDs, essentially. So it was a disappointing and neutral study. So there was a lot of conflicting results initially. Nobody knew why, but in this elegant paper of Mishra et al. In the JBMR in 2011, they looked at 140 girls with anorexia nervosa against 40 control. They gave them estradiol patches, and they gave them cyclical progesterone to get them to have withdrawal bleed. And what they've noticed, so this is they divided them into 3 arms: the anorexia nervosa without estrogen supplement, anorexia nervosa with estrogen supplement, and the control in the white bars. And of course, as you would expect, in the AN group without any hormone therapy, replacement therapy, they lost their BMDs over 18 months. Those who had estrogen supplement has a comparable BMD to the control. So it did work. How about the athletes with FHA? Another 3-arm RCT controls versus transdermal versus OCP. And I think this is pretty important. They have 3 arms. They give all of them vitamin D calcium supplement, and all were of normal weight. So weight was not an issue. It was driven by Red's group. And where you could see here that the bone density lumbar femoral total hip in the estradiol patch supplement has improved. The non-estrogen has dropped down in the lumbar spine as you would expect, and dropped down again in the femoral neck and the total hip. And the OCP, those who were given contraceptive pills, they have comparable drop to those who were not given estrogen, as if you have given them nothing. As a matter of fact, the total hip, the pill group has a worse reduction in the bone mineral density than those who were given nothing. And essentially, the message we get from this excellent Eckermann group paper, is that if you were to give something to help with the bones, it's got to be of biosimilar estrogen, and that is estradiol. تريد تعطي شيء يفيد العظام، اعطي estradiol. تريد تعطي شيء آخر بس ethinyl estrogen, it will help with the symptoms and the hot flashes, but it will not help with the bones that much. The reason being why the oral contraceptive does not work on the bones in these two groups of POI and functional hypothalamic amenorrhea. The reason being is the oral contraceptive pills will lower the IGF-1. مثل ما نعرف احنا بالأكراميجا نعطيهم contraceptive pills to help with the statin somatostatin analogs للنيريتاد وابتريتاد وما إلى ذلك, and it will increase the higher SHBG. So higher SHBG will capture more estrogen available, and you will have less free estrogen available in the plasma, and therefore it will lower the free estrogen. Ethinyl estradiol is not as effective as the biosimilar estradiol. This is the message. So the route of the estrogen supplement, we prefer transdermal as opposed to oral, and the OCP covers 21 days out of 28. فإذا تريد مضطر تعطي OCP, ممكن تختار OCP that has a biosimilar estrogen, that is estradiol, مو ethinyl estrogen. وتعطيها انه تعطيها continuous, يعني لا توقف ال 21 days وتعطي sugar pills for last 7 days, لأن المريضة بهاي الحالة راح تخسر 25% of the estrogen supply. The OCP should not be used to regain menses, but rather cognitive therapy or increase energy intake. هذا more important. Cognitive therapy, psychotherapy plus good energy intake more important than the OCP in regaining the cycle. And OCP better avoided when you're addressing BMD. If you can use transdermal, خير على خير. ماكو transdermal بالعراق, استخدم ال OCP with biosimilar estrogen, and bisphosphonate is not recommended. هذا المهم بالموضوع. مثل male hypogonadism with osteoporosis, we prefer not to give them any bisphosphonate. The only exception, if you have very severe osteoporosis, like a Z-score of -3.5 or ما إلى ذلك, or fractures, then you can give a one-off Zoli every 5 or 10 years, but you have to replace their hormones first, concomitant hormone replacement, because this is the mainstay treatment. Now, the choice of hormone therapy in POI, transdermal we prefer, or estradiol 2 milligram once a day. So you got the answer. ده كنت تسأل أي نوع estradiol 2 milligram once a day. Please do remember that half of them will have on and off ovulation. That's a good thing. If they need contraception لأنه هي المريضة متزوجة وما تريد يصير عندها أطفال, then you can use, as I said, contraceptive pills في هذه الحالة. But you skip the sugar pills and try to use a biosimilar estradiol-based contraceptive pills. We'll move on to case 3, a 42-year-old female referred by oncologist after recent DEXA scan that showed osteoporosis. She has a breast cancer in 2019, which were ERPR positive, treated with wide lesion resection or excision with chemo and radiotherapy, and she was commenced on Zoladex and letrozole. She had bilateral oophorectomy, and the Zoladex was ceased, and she continued to have letrozole, and she had a past history of hypothyroidism. She also had non-Hodgkin lymphoma, and she had a stem cell transplant, and she did not have any history of fractures. That's her usual medication. She's a non-smoker. She had initially amenorrhea من خلالها stem cell transplant, but then that will disappear. She resumed spontaneous conception. She's currently have regular periods while prior to the breast cancer, and she had developed amenorrhea since the chemotherapy in 2020, early 20. Her DEXA scan is noted here for osteoporosis, femoral neck of moderate osteopenia in the femoral neck. And again, the same question arises: what sort of treatment you would give her? Just vitamin D, calcium, and exercise, Zoli 4 milligram biannually, oral bisphosphonate, denosumab, إلى آخره, or the transdermal patch. So to start with, the choices of MHT in this group: tamoxifen is an inhibitor of estrogen receptor in the premenopausal and agonist in the postmenopausal. So if you give tamoxifen to a younger patient, she will develop hot flushes. Older patient, they will not. In the allogenic, this is another elegant paper that showed that the bone marrow transplant causes osteoporosis through multiple mechanisms. One of them is hypogonadism, inflammatory cytokines, increase in allogenic stem cell transplant, and of course the immune therapy that you use, including steroids. But generally speaking, this is the answer you got here. If you give only vitamin D and calcium, they continue to lose bone density in the femoral neck and lumbar spine as well, equally. If you give them HRT, it almost levels, make it flat, so it doesn't drop as much. If you give them risedronate alongside the calcium and vitamin D, it keep them level. But if you give them Zoli, it actually improves their BMD, both in the lumbar and the femoral neck. It's well known now that tamoxifen in the premenopausal females or age will increase the risk of fractures by almost triple it. While if you give gonadotropin releasing hormone, the Zoladex, this will increase the risk by about 66%. In another study, it showed the risk increased by 5% with tamoxifen. Tamoxifen plus GnRH will increase by 6%. However, if you give aromatase inhibitors, the risk goes up by almost 8%, and that's in the premenopausal. Now, the story is quite different in the menopausal females, where the tamoxifen has not shown any impact on increased risk of fragility fractures. While aromatase inhibitors has been still associated with fragility fractures. They're well known to cause it. Number needed to harm is 72 in 3 years and 46 in over 5 years period. The indication for bone-specific therapy, anti-resorptive with breast cancer survival. This depends if the patient is going to be on aromatase inhibitors, as the majority of them will be, or the less likely without aromatase inhibitors. So we do have, this is an indication for us to consider anti-resorptive with aromatase inhibitors. This is the task force, Australian task force here by Mathis, our Mathis Grossman and his group, and they considered the aromatase anti-resorptive therapy with bisphosphonate. This is, remember, this is a high turnover, so you don't want to give anabolic because it will make it worse. You give anti-resorptive. If the T or Z score is lower than -1, plus 2 or more risk factors for osteoporosis, whatever risk factors, smoking, other condition, it's steroids, you name it. If there is a history of fragility fracture, if the T-score is -2 at any site, regardless, -2.5, and below. Modest osteopenia, you treat. And because we know that the AI is associated with, مثل ما قلنا, number need to harm is 40 plus. Annual bone loss more than 5% or 0.05 gram per square centimeters. And if you can do the FRAX, please do remember that the FRAX is validated against menopausal, not premenopausal age. فهذه هي الحقيقة جدا مهمة إنه that's why we have to do serial BMDs. لأنه إذا كانت البون loss أكثر من 5% that's an indication to whilst on the AI. وبالمناسبة مهم جدا نعرف إنه من تبدي العلاج هذا ما توقفه إلا بعد سنتين من ما توقف ال AI. مو رأسا توقفت، بقي يستمر سنتين بعد ال aromatase inhibitor. Now those who are not on aromatase inhibitors, then you would consider HRT if possible, which is, fraction minority could qualify. Or there is a ongoing decline in BMD more than 5% as mentioned, or they sustained fragility fractures regardless of the BMD drop. And please do remember that teriparatide is contraindicated in these cases because of potential of sarcomas. And the residuronate or oral bisphosphonate has a short half-life, and it has a minimum or modest impact on the linear skeleton bones. It's mainly improve the trabecular spinal bones. So zoledronic acid biannually 4 milligram is the way to go if they qualify. With this slide, I end up this talk, and I hope to see you next month with in our endocrine monthly grand round. Thank you all.